For the presidential oration, I would like to invite the chairpersons Dr. Anuradha Ridorkar ma'am and Dr. Vaidehi Marathe ma'am. I request
Dr. Anuradha Ridorkar ma'am, a senior consultant at Kingsway Hospital. She requires no introduction. She is a firebrand orator, past president Nagpur OBGY Society, past chairperson of Maharashtra State Women Doctors Wing, winner of Maharashtra Government Dr. Anandibai Joshi Award for Mother and Child Care. She has received various awards and is a known face and name in most of the gatherings. But a very short intro that I have from my own experience, she is a very powerful, dynamic, and a straightforward, bold person who speaks right from her heart. Welcome you, ma'am, for the oration. Dr. Vaidehi Marathe, ma'am. She is one of the most dynamic presidents this organization has ever had. She is the Foxy representative installed today, and she is the director of Mahir Maternity and Nursing Home. She is the receiver of MS Signature Award consecutively 2 years in a row, and she has brought laurels to NOGS by winning 2 National Foxy Awards in a single year. We welcome you, ma'am.
I request Chairperson Dr. Vaidehi Marathe ma'am to kindly introduce our orator, President Dr. Warsha Dhawale ma'am.
Thank you, Riju and Amok. You guys have done a fabulous job, I must say that.
Thank you,
and thanks for your sweet introduction. Respected seniors, teachers, and my dear friends. It's such an honor to chair the prestigious NOGS presidential oration, which becomes all the more special because it's being delivered by a special person in my life, my dear friend Warsha. And it's my sweet pleasure to introduce her. She's already been introduced by another special friend in his special style, so I'll not repeat what has already been told. I remember my first interaction with her many moons ago in IMA, where she was a very active member, and I was instantly impressed by her persona, someone with whom I felt an instant connect. And since then, we have shared a distinctive bond. Wo Fevicol ka jod, you know? No wonder we were mistaken as the twin sisters for the longest time till I started growing my hair. Another very interesting thing I came to know about both of us today is that although we all of us, Chaitanya, me and Warsha and Alka, all of us belong to the same batch, 86 batch, but I belong to another college. I was in Amravati. And both of us share the same roll number because I was also on the second merit list in that college. So we were both 86002. So this lady is an all-rounder, great orator, great academician, bold surgeon, super artist, efficient administrator, and a great friend. She is a no-nonsense person. जो बात मन में वो ही बात जुबां पे ऐसी है उसकी फितरत सीधी बात नो बकवास इसलिए मैं बोलती हूँ बॉस है बॉस शी इज़ द लेडी पुष्पा वर्षा बोले तो पानी समझे क्या लावा है लावा झुकेगी नहीं साला झुकेगी नहीं for her principles and for the right decisions that she takes in her life. I'm sure this lady is going to hit a super successful innings this year with her all-round performance and she'll win everyone's hearts. So ladies and gentlemen, तालियों की गूंज के साथ please welcome Dr. Warsha Dhawale, the first lady of NOGS. Warsha, the floor is all yours.
Thank you. My God, today I am just getting overwhelming intros. I really didn't know these people had so many things in store for me. Okay, so it's, almost 2 o'clock. I won't take much of the time. I know you all are hungry and waiting for the lunch there. I'll just rush through. Today is the day I am standing here before you to deliver this prestigious oration after accepting the post of the President of NOGS 22-23. With blessings from God and knowledge of wisdom, I take you to a small journey, a small talk of avoiding the black coat. I am not a lawyer, but I do belong to a family of lawyers, and I do have so many lawyers surrounding me. So probably by that instinct, I do have that gene trait which is being carried in my family. But my interest in medical legal has really kept me more and more into the medical legal matters. So today, every obstetrician's dream, you all will agree with me, is safe motherhood and a healthy baby. And every obstetrician's nightmare is one opportunity that got missed and it turned out to be a nightmare for her. So today we as obstetricians and gynecologists are dealing with so many patients, ANC patients, PNC patients, pediatric adolescent patients, and we encounter problems everywhere. Every obstetric case has a potential for litigation, you all will agree. We say that nahi, usse to kuch nahi hone wala hai. This is a very, very simple case, kuch nahi hoga. But no, you never know which of the case will give you a goosebumps. Everything appears smooth until you land up with a serious complication. The first thing which hits you is, oh my God, is it medical legal? Will it be a litigation? Why did this happen? What went wrong where? Multiple frames start coming before you. Retrospectively, the sequence of events, you try to find out, अरे मैंने गलती कहाँ की? ये तो मैंने बराबर किया, वो भी बराबर किया, ये ऐसा किया, फिर गलत कहाँ हुआ? ऐसा क्यों हुआ? So these are the multiple frames which start appearing before you. Unprepared emergencies. We as obstetricians, पता है, शाम को 6 बजे फंक्शन है, 5 बजे मीटिंग है, मैडम मेरी पेशेंट लेबर में आ गई. So unprepared emergencies is the day or is the word for all gynecologists. Head-on collisions. You are expecting one, you get too many emergencies, too many cases, too many problems at a time. No fault of mine. बहुत बार ऐसे होता है, you are standing on the signal, somebody comes and hits you, right? It's not your fault. Same thing happens with us also. We incur medical accidents. We incur surgical accidents. And recently we know what we have gone through. Yes, Archana Sharma laid down her life because she was under pressure, which nobody should be doing. The thing which she did was wrong. I should say that she was a coward in that situation. But I really don't know what situation she went through, and she took this extreme step of leaving the world. But this is not the solution for all of us. Wrong decisions. Who says you can be right all the time? You can take wrong decisions. But does that mean that you should be punished for your wrong decisions? Never. You always learn by your mistakes. You always learn with your experience. So there can be some wrong decisions too. Overconfidence. Nobody should have this. You should always have confidence to that level that you are confident, but not that level that makes you overconfident. Now, in this era of litigations, we know that there are increasing incidences of operative interference. We had such a nice talk by Jaideep. We have increasing awareness amongst the public. Easy approach to many setups. यहाँ नहीं हो रहा, अगली गली में दूसरा है setup, चलो वो डॉक्टर के पास में चले जाते. You have so many doctor friends around you who can give you n number of advice right from morning to evening, and they'll tell you that यहाँ जाओ, वहाँ जाओ, ये होता है, वो होता है. Cross-pathy is booming. Nobody can say that we in India have been permitted with so many pathies running. Nobody is here to cross-check. When it comes to maternal mortality or morbidity, or it comes to cesarean sections, it is we the gynecologists who are there. But What about the others who are practicing as gynecologists? What about the quacks? What about the crosspathy, which is booming here? And professional rivalry. We in our tenure, I remember Chaitanya had kept the tagline as avoid medical jousting. We are all practicing. See, we are all समंदर में हम एक ही जगह पे सब लोग रहते हैं. Why should we talk bad about each other? We never know कौन किसके काम में कब आएगा. And you should never underestimate anybody. जितना भी छोटा इंसान हो कभी कभी वो बहुत बड़े काम में आता है. So that should be avoided. And how is the 21st century patient nowadays? They can benefit from the laws which are more patient friendly. They have more access to information thanks to Dr. Google at their fingertips. कुछ भी हो, before entering your chamber, they'll tell you, हाँ डॉक्टर आप बिल्कुल वैसे ही बताते हो सही जैसे गूगल ने बताया है. So they are well read, well knowledge, up to date. And अगर you're telling something else which is not said by Google, then बोलेंगे अच्छा ऐसा तो गूगल ने नहीं कहा था, right? So they are the patients who are well versed. And you have to be prepared for a rapid fire of questions, whether they are related or non-related. So many IT public, they come wearing those half pants and chapla घालून येतात आतमध्ये. No manners, no etiquettes, but then they'll just shoo you down. What is this? What is that? Why is this? Why not that? Why not that? You are not sitting there to answer each and every question, especially those which are not related to your patients. So here comes in your confidence, and of course 5-star services at peanut prices. Everybody wants good services, everything good at the beck and call. Give a phone call, you want the doctor to be ready with everything, and when it comes to money, they just take a back foot. So this 21st century doctor, what about this? He is faced by the uncertainties in the law, just like Jaideep sir told that we have more laws regulating the OBGY persons than the transplant persons, right? So we have so many laws, and nowadays we have seen, abhi we have all done renewal of our hospitals. We've seen how many audits and all we have to conduct. How many times we have to prove to the society that we are doing good work and we will be doing good work. There are only handful of people who are doing bad work, and these handful of people of doing the bad work should be the ones who should be punished and not the ones who are doing good work. Maybe we are not equipped to deal with the recent demands. We have to update ourselves, practice always the evidence-based medicine, document everything what we done, and then of course the big question of small hospitals versus the big giants. And here again, डॉक्टर लोक खूप पैसे घेतात, असं करतात, लुबाडतात, लुटतात, everything comes on. The Consumer Protection Act, we all know that this act has come, and जागो ग्राहक जागो, तो ग्राहक जरा ज़्यादा ही जाग गया है. Every time it will be like they'll keep on pointing fingers at you. We know that this is an anti-doctor act. This was done actually for the consumer safety. Now, what are the apprehensions of CPA? We know that it has caused a bad doctor-patient relationship because the faith is lost. That nazuk, delicate thread which was there linking the patient and the doctor, that is lost. What has happened is, whenever the patient comes to you, you are advising few investigations. या डॉक्टरकडे लॅब आहे, नक्की कमिशन असेल. या डॉक्टरकडे दुकान आहे खाली, नक्की कमिशन असेल. This is what the patient comes to you. The patient is prejudiced when he comes to you. And we think that we shouldn't be missing out anything. So we are doing a battery of tests. So on both the sides, even they are right, even we are right, right? There is a tendency to manipulate. Nowadays, we've seen that covering so many TPAs, insurance policies, the right diagnosis is never given to the patient. The right things are never performed with the patient. This is only to create your bills and to get the bills reimbursed. Doctors charge more. We all know who gets the pie when it comes to huge, fatty, inflated bills. Coming to a few scenarios in your daily practice, these are just cases, right? And there is a disclaimer that you can say that contains scene that some viewers may find correlating. So each and every one of us can correlate it somewhere or the other. Now here it's like you have a patient with 7-month PROM, you have a patient coming with abnormal presentation, with twins, with postpartum hemorrhage, chorioamnionitis, maternal infections, placenta previa and abruptions. So, in a case scenario, patient was operated for a C-section. She complained of severe pain in abdomen. Post-op third, fourth day, she was investigated. She was given medications. She had no relief, but then the pain was mistaken for a surgical pain. Analgesics were added, and patient was discharged. She landed up with another doctor because this doctor was not listening, or maybe she was referred by another of her good friend. Laparotomy was done after suspecting mass in the abdomen, and abdominal sponge was found. Now this is quite a old case. Nowadays I think we find less of cases having sponges and instruments in the abdomen, but this definitely has come to the consumer redressal forum. 30 weeks primary, sudden onset PIH happens so many times because the ANC follow-up, though it is good, you call the patient, but the patients don't report to you. They come to you only when मला खूप पायावर सूज आली आहे, चेहरा सुजलेला आहे, घरी म्हणतात आहे की तू खूप लठ्ठ झाली की काय सूज आली, चल डॉक्टरकडे. Sudden onset hypertension, uncontrolled PET, intervention required, you do a section, baby is shifted to the PVU, huge amount is spent and you lose the baby. Another scenario, 32 weeks, uncontrolled hypertension, lands up in APH, emergency LSCS, baby is a stillbirth. 30 weeks, central placenta previa, tap bleed, emergency LSCS, severe PPH, lands up with caesarean hysterectomy, and as she was a primary, there is no live issue. ANC 8 months, undetected uncontrolled hypertension, emergency section, baby does not cry after birth, cerebral hypoxia, later cries after intubation, mental retardation, MRCP. Primary with twins, either it's a short cervix, she delivers, she develops PIH, LSCS done, blood is not arranged, patient time is lost, patient goes into DNC and the patient dies. Patient develops GDM, which is very common, initially controlled, later on not controlled, LSCS develops, babies develop RDS, both the babies succumb. Diagnosed as oligo-IUGR, managed well, came to you with sudden loss of movements, outcome is no FHR, and on investigation it was found as a IUFD. Patient is admitted with loss of fetal movements, not in labor. FHS located, appear, clear. Patient takes the discharge from hospital की आता सगळं ठीक वाटतंय, चांगलं वाटतंय. Comes later in the day, same day again, no FHS, IUD baby. All these cases which I have said are all true cases. Only the thing is, I have not labeled them properly. It is just like because we are getting such type of cases. So you should remember any ANC, whether she is non-complicated or complicated, with medical conditions like diabetes, hypertension, asthma, epilepsy, cardiovascular diseases, all should be treated as high-risk patients. Every operative patient is a potential medico-legal attraction, so you have to play safe. Now, introspection as to why litigations happen. In our practice, we have delivered so many patients, we have seen so many patients, but litigations occur only in few. Now why these happen? Either the mother or the baby is compromised, there is a communication gap, transparency. You do not try to communicate with the patient what you want. Inflated hospital bills. Now these are the three major things where litigations happen. Introspection. Inadequate history taking. Most of the time it is seen that the patient comes with only one-page history. Nothing is written. सगळे 9 महिन्याचा पूर्ण चिठ्ठा जो असतो that is on one page. Everything, including her USG report and investigation and checkups and everything. You can only find out if patient is a high risk if you take a detailed history, if you pick up the points properly, routine examinations and investigations. You can never say if the patient is coming to you regularly, then it is your responsibility to pick up the high risk points. Failure of timely referrals creates medico-legal problem. You think that you can manage the patient and you keep on holding the patient at your place, and then when matters go out of hand, you are referring the patient. Such things should never happen. You should always and always know your limitations and your setup's limitation. Both the limitations should be known to you, and then only you can properly refer the patient, and then only the patient can be saved. Displeasure, I told you, medical josting. Death of the mother intrapartum, postpartum, just what had happened in the Archana Verma case, right? Neurological or bodily injuries. Whenever you are giving them a baby who is not healthy, who is having some problem, then litigations do happen. FDA recommendation drugs should be used. Off-label drugs should not be used, and if they are used, you should properly document them, because if there is negligence, some damage happens, then you are liable for a strong medico-legal action. I will not talk on this because Jaideep has already stressed upon this, that is the alarming rate of cesarean section. You should know when to strike your blade. Too early cesarean sections can lead to prematurity, LBW and RDS. Too late can lead to maternal and fetal morbidity and mortality. So it is a double-edged sword for us gynecologists. So important points to remember: a doctor is not liable for an error of judgment or of diagnosis if he or she has secured all the necessary data for sound judgment. What does this mean? This means that you are not liable for negligence if you have done your job properly, right? This is in our language. Contributory negligence on the part of the patient is a very good defense. What does this mean? This means that if you are calling the patient for follow-up, she is not coming at a proper time. You are advising the patient a few investigations, she is not doing it. So you should write this down on your file. This amounts to contributory negligence on the part of the patient. So prevention is always better than cure, and so you should always be wearing a safety belt. And safety belt for us are all these IPC sections who protect us from the law. You should know that when an FIR is lodged against a doctor from the death of the patient who was under his treatment, under the IPC 304A, the doctor can be arrested. Yes, but this is a bailable offense. And what is a non-bailable offense? IPC 304. That is a non-bailable offense which was put on the poor doctor who lost her life. And the Supreme Court's judgment on this is, unless and until negligence is proved, you cannot arrest the doctor on this IPC. Now, what is medical negligence? Medical negligence is an act of commission or omission by a doctor whereby harm is caused to the patient. An act of commission means you are committing something, means where the doctor has done something which has resulted in the harm to the patient. Like you are amputating a different limb or operating on something else. This doesn't happen with us though, but sometimes there can be confusing situations, and leaving some instrument or mop which nobody does in their good senses. And what is an act of omission? Omission means you are not doing something which is required to be done of you for that instance. For that instance, if you are managing the patient and you feel the patient cannot be managed, I have to refer the patient. Holding back the patient and putting the patient under somebody else's care who is not that efficient is called as an act of omission. So what should be the plan? Plan should always be proactive. You should always think, how can I help this patient? When can I do the necessary things? Where should I be referring this patient? Why should I be doing this? Because my setup is not that up to date or updated. And whom should I be doing this? Preventive measures. How to avoid litigations. There are three aspects of reasonable skill and care for prevention. One is the medical, second is social, third is legal. So there are three aspects. In medical, first and foremost, it is imperative for every doctor, hospital, nursing home to exercise this care with an average person with equivalent qualification and experience in similar circumstances. We have all done our MBBS, we have all done our MD. During MD, whatever has been taught in our curriculum, that is what is expected of you to do when you start your practice. You are not expected to do something beyond your reasonable skill and care. If you are injuring a bladder, you are expected to stitch it if you know. If not, you should be calling the proper person to do it. So this is what is the reasonable skill and care. You are not expected to perform something really extraordinary, and you are also not expected to experiment with the patient. Social aspect. We should always exhibit our reasonable skill and care through our feelings, which most of us don't do. We kind of, being gynecologists, are like, आत्ताच यायचं होतं का, हिला 12 वाजताच पोटात दुखलं का, आता मला बाहेर जायचं आहे, ऐन वेळेवर येणार, इमर्जन्सी. दिस इज व्हॉट वी डू. म्हणजे सगळ्यात पहिला फोन आपला पेशंटला असाच होतो, तुला आत्ताच दुखायला लागलं आहे का, किती वाजतापासून दुखत होतं, का नाही आली तू, राईट? सो दिस इज हाऊ यू कीप ऑन. बट आय शुड ॲडमायर वन थिंग अबाउट आवर पास्ट प्रेसिडेंट चैतन्य. वी शुड लर्न हाऊ टू टॉक टू द पेशंट्स अँड ऑफकोर्स इतका छान बोलतो तो, कधीच तो कोणावर रागवत नाही. मला म्हणायचं, वर्ष तू चिडते का, तू अशी का करते, शांत राहा. सो दॅट इज व्हॉट आय रिअली वॉन्ट टू लर्न फ्रॉम हिम आफ्टर दिस इयर, राईट? नॉट नाव. So expressions, body language, action and discussion, communication, all these matter a lot, and through these only your patients know. आल्याबरोबर if the patient says, मॅडम तुम्हाला पाहिल्यावर ना खूप छान वाटतं, अर्धा आमचा आजार तसाच चालला जातो. दिस इज व्हॉट यू हॅव गेन्ड इन युअर प्रॅक्टिस. आल्याबरोबर मला जायचं नाही त्यांच्याकडे, पण मला काही पर्यायच नाही आहे, असं जर आपण ऐकलं तर वी डोंट फील गुड, राईट? सो वी शुड बी समवन हू कॅन प्रेझेंट विथ ऑल दीज क्वालिटीज as and when to the patients. We may be very sincere in our duties, but most of the times कसं आहे, sincerity असल्यानंतर you do not, तुम्ही बोलत नाही, you don't communicate with the patient, and here is where the fault lies. If you communicate with the patient each and every time, they always feel that they are in the loop, they are connected. लीगल ॲस्पेक्टमध्ये आपण पहिलं फारच पोर होतो, पण आता इतके वेबिनार्स आणि इतके अकॅडमिक्सनी आपल्याला शिकवलं की वी हॅव ऑल बिकम ऑल एक्सपर्ट्स नाव. So this includes documentation, exercising reasonable skill and care in consultation, diagnosis and treatment. Whatever we are doing or whatever we are treating the patient, please record everything in a legible handwriting. Nowadays we have the EMRs, the electronic medical records, those can help us. Whenever there is a failure by the patient to follow your instruction, that is refuse to do any investigation, this failure for review when she comes, first of all what you should do is underline. पेशंटला बोलवलं होतं 15 दिवसांनी, पेशंट 1 महिन्यानी आली, पेशंट रिपोर्टेड टू मी आफ्टर 1 month. अंडरलाईन, बिकॉज दॅट इज व्हॉट इज गोइंग टू हेल्प यू. या एका महिन्यात तिला IUGR झाला, ऑलिगो झालं, तिचं FGR झाला, हू यू आर नॉट रिस्पॉन्सिबल. यू हॅव ऑलरेडी कॉल्ड हर, शी इज रिस्पॉन्सिबल अँड यू हॅव टू एक्सप्लेन दॅट टू हर. These negative records can always and always help you. How much importance is given to consent and informed consent? How many webinars and talks we have had on consent, but really how many times are we taking a proper consent? एक साधा कागद असतो, त्याच्यावर सही घेतली की झाली. वी डू नॉट एक्सप्लेन द प्रोसिजर टू द पेशंट. वी डू नॉट एक्सप्लेन द कॉम्प्लिकेशन, द साईड इफेक्ट्स of anesthesia and the regarding procedure. We do not explain to the patient who is coming for the surgery, who is going to do the surgery, who is going to give what type of anesthesia and what complications can be there. So informed consent means you have to take a proper consent, and this is the only paper which can save you from litigations. Criminal liability as well as civil liability. Why? Because criminal liability and civil, because if you take a proper consent and if the patient has signed that paper, that means the patient has agreed to all whatever complications and side effects you have told. So informed consent is always better. It gives you a good defense regarding side effect and complication, and if the patient suffers through those, you can always say that these were explained to you and the patient has undergone similar complications. Handing over of the documents, medical records of the patient, indoor OPD investigations. We all do OPDs, but we never keep a record of the OPD, which is required for us to do, but many of them, so many of them don't do it. Should all the OPD papers be also maintained by the hospital? Yes, we are required to maintain each and every paper, even if it is OPD. Indoor papers are maintained by everyone. Should discharge cards be given to all patients? Yes. It is mandatory. Most of the times the patient comes to you, no discharge card is there, no referral slip is there. मॅडम माझं ऑपरेशन झालेलं होतं, कशाचं झालं माहिती नाही, डॉक्टरने सांगितलं की आम्ही करून टाकलेलं आहे, आमच्याकडे तुमचे कागद आहेत. You should never do like that. Whenever the patient is leaving your hospital, whether she is satisfied, whether you are satisfied or unsatisfied, give all the papers to the patient. You can take a signature that I have handed over everything. If by the court, you have to give everything. Patient wants a tubectomy, whether it is an interval tubectomy or a post LSCS, or her child is 5 years, 2 years. Now we know the norms have changed to 1 year. So is the husband's consent necessary for tubectomy? Yes. It is necessary, it is mandatory. It's not like MTP wherein you can only go ahead with the patient's consent. The consent for tubectomy, husband's consent is necessary. Now regarding sterilization and tubectomy, few things everybody should remember, that this is a national health policy and the documentation of this is must. You have to keep a record. Registration of your center is also must, and counseling of the risk and complications should be done. Why? Because if you don't do, this is how the patient presents to you. तुम्ही तर माझा ट्युबेक्टॉमी केलेलं होतं, मग आता हे पॉझिटिव्ह आलं कसं? Right? So the first and foremost thing which you should be doing while doing a tubectomy is this complication, this operation is not 100% proof. Failures can occur, and in failures you can be pregnant. So if the patient comes to you in early pregnancy, are you liable to do her MTP free of cost? If she wants to continue, is the liability your burden that she should come to you and she should deliver it with you, or she sends you a compensation notice? One thing I want to touch on this, Muhurtam section. तुम्ही असं करा, नेक्स्ट वेडनसडे विल डू अ सेक्शन. मॅडम थांबा, आम्ही पंडितजीला बोलवतो. मग आमचा पंडित सांगतो, काय सांगतो? की मेनी ऑब्स्टेट्रिशियन्स अँड गायनेकोलॉजिस्ट आर प्रमोटिंग दिस फॉर वेरियस इंडिकेशन्स. सी, वी हॅव आर मॅटर्नल इंडिकेशन्स, वी हॅव आर फिटल इंडिकेशन्स. We are telling the patient that this may be a suitable day. We don't give a date. We actually give a few days की तुम्ही हे करा म्हणून. But then the patient says, okay, या दिवसात करायचं आहे. They take their appointment. They take first, before taking your appointment, they take the appointment of पंडितजी. आमच्या पंडितने आम्हाला सांगितलेलं इतके वाजता करायचं. म्हणजे 9:45 ते 10च्या मध्येच आम्हाला बाळ पाहिजे. म्हणजे आर यू क्रिएटिंग सुपर ह्युमन बेबीज आफ्टर दिस? कोणी तुम्हाला याच्यानंतर नॅचरल दिसणार नाही आहे. So this is where I think we should try to be rigid in our decisions, that yes, you have to do a cesarean section is needed for you, but timing साठी if you are saying in the dead of night रात्री 11:15 वाजता करून द्या, कॉर्ड कट करायला आम्हाला ग्लव्स घालून द्या आणि आम्ही येऊन ते कॉर्ड कट करू, तुम्ही तुमचं काम करणार नाही आहे. अँड मेनी ऑफ द साऊथ हॉस्पिटल्स आर चार्जिंग 10,000, 20,000 हजार. तुम्ही पंडितजीला किती देता? वन ऑफ माय पेशंट्स केम अँड सेड, मी पंडितजीला 10,000 रुपये दिले. म्हटलं पुट दॅट इन माय बिल इफ आय एम गोइंग टू डू अ सेक्शन नाव. राईट? सो दीज आर द थिंग्स विच आर देअर. वी शुड नेवर प्रमोट ऑल दिस थिंग्स. देर शुड, आय ॲक्च्युली मला जयदीप समोर सांगायचं होतं की सम लीगल समथिंग शुड कम आउट ऑफ दिस. इलेक्टिव्ह सर्जरीज and legal opinion on this. So what are the do's for the doctors? Special tips, I'm just finishing in a few slides. Mention your qualification, training, experiences, designation on your prescription or your letterhead. Qualification means recognized degrees and diplomas as they are with the IMC. Scholarship, memberships, awards do not qualify to adorn your letterhead unless they are very, very prestigious. Otherwise letterhead असतं A4 साईजचा, अर्धा तर त्याच्यामध्ये फक्त डिग्र्याच असतात सगळ्यांच्या, अवॉर्ड्स आणि फेलोशिप्स. दिस शुड नॉट बी देअर. इट शुड बी व्हेरी सिम्पल, से स्टेटिंग योर क्वालिफिकेशन. ऑलवेज मेन्शन डेट अँड टायमिंग ऑफ कन्सल्टेशन. मेनी अ टाइम्स पेशंट कम्स टू यू, त्याच्यावर डेटही नसतं ना त्याच्यावर टायमिंग तर कोणी लिहत नाही म्हणा, पण ॲटलीस्ट डेट शुड बी देअर. ऑलवेज मेन्शन द एज, सेक्स, वेट. वी नो हाऊ इम्पॉर्टंट इट इज टू मेन्शन द एज ऑफ द पेशंट. पॉक्सो इज देअर ऑन आवर हेड्स. Listen attentively, look carefully, ask intelligent questions. Ask only those that are required. In case you have been interrupted by some urgent calls, apologize and start again with the patient. But I will say here that we are not interrupted by our calls, but we are interrupted by the patient's calls. Because सगळे मोबाईल घेऊन आतमध्ये येतात, आल्याबरोबर त्यांचे मोबाईल वाजायला लागतात सगळे. Always ask the patient for review. If you are seeing the patient in a history, you have to go for some surgery and you are saying that yes, I want to review you again, so please write and tell him that please come again in the next visit. In complicated cases, record precise illness and findings. History of drug allergy, it is so important. Most of them don't even know. चुकून वोवेरॉन दिला जातं, चुकून सिफ्रान दिला जातं. ऑल दीज अँटीबायोटिक्स पेशंट मे बी ॲलर्जिक अँड शी डझंट टेल यू. मग म्हणतात की तुम्ही विचारलंच कुठे आम्हाला की आम्हाला ॲलर्जी आहे का, हिस्ट्री आहे का. सो ऑलवेज अँड ऑलवेज मेक इट अ पॉईंट. रँडम हिस्ट्री आपण जेव्हा विचारतो, आर यू ॲलर्जिक टू एनी ड्रग, आर यू ॲलर्जिक टू एनी मेडिसिन, and write the names properly. If she says ki I am allergic to something, write it on your file, make it a proper box, put a red pen underline. Inform the patient clearly of the side effects of the drugs which are prescribed. एव्हरी टाईम यू प्रिस्क्राईब मला जास्ती पॉवरच्या द्यायच्या नाही, मला चालत नाही. अरे बट दॅट मच इज नीडेड फॉर यू, अदरवाईज हाव आर यू गोइंग टू बी ट्रीटेड? इट कॅन कॉज रेजिस्टन्स इफ आय डोंट गिव्ह यू इन द प्रॉपर डोज. Certain drugs, if prescribed for a longer duration, require additional support of investigations. Please do not forget to mention. Mention if the prognosis is explained and take consent in local language. तिला मराठीत समजत असेल तर मराठीत लिहा, हिंदीत समजत असेल तर हिंदीत लिहा, पण यू हॅव टू टेक दॅट. इफ नेसेसरी टेक अ सिग्नेचर ऑफ द पेशंट, अटेंडंट, and you yourself also sign on that yes, in front of everyone this has been explained. Whenever you are referring the patient, give a proper referral note. Update not only your knowledge and skills, we are always updating ourselves, CMEs and all these are for us only, but what about your staff? If the staff is not updated and if the staff doesn't know what to do, you are handicapped in a private situation. Update your facilities also, preferably employ all qualified persons. If not, give them proper training so that they can be useful to you. Take proper consents. In all instances of swabs and instrumental cases, the surgeon in charge, whether you have done the mistake or he has done the mistake or she has done the mistake, the direct or vicarious liability is held on the surgeon in charge. Therefore, personal insurance and safety should be a priority. Always and always seek a medico-legal opinion before you file a reply whenever you get a notice. Few things to remember: keep a count of your instruments. Abdominal mops, sponges should be counted before the surgery, after surgery. Do not keep gauze pieces. खूप जणांना सवय असतं, खूप क्लटरिंग करून ठेवून देतात तुमच्या याच्यावर ट्रॉलीवर. You shouldn't do that. Emergency drugs for anesthesia and PPH should always and always be ready, or otherwise for a single ampoule of atropine you have to make the hospital run around. Sutures should be ready. Extra sutures should be ready because you do not know when your needle will come off and when you can have a bad suture in hand. Suction machine should be checked. नुसतीच घरघर आवाज येतोय नाही. See whether it is really doing its function. For each and every LSCS, availability of blood should be checked mandatorily. Always take a sample of cross match for the patient. It doesn't, एकच ml blood लागतं फक्त cross match साठी. Pediatrician should be available. Most of the hospital नाही काय नाही, ठीक आहे आपण पाहून घेऊ नंतर काय होतं. When the baby is in apnea, you understand की what is important. Intubation set for the baby should be made available. आपल्याकडे असतं, पण त्याच्यात आहेत का, बॅटरीज आहेत का, वर्किंग आहेत का, चालू आहे का, वेळेवर काहीच लागत नाही, and that is a very very horrible situation. Lights should be in proper place. Always check hemostasis and hemodynamics before closing the abdomen. Doubtful patients, you can always keep a drain. These are the various rights and privileges of the RMP under the Act. You can choose patient, you can practice medicine, dispense medicine, recovery of fees, खूप मुश्किल आहे, and you have a right to issue medical certificates when they are for the right cause. So doctor and MLC, every doctor under the law is bound by a contract to serve the patient, and you cannot refuse treatment. First aid ka hoina, you have to give. MLC examination and reporting is one of the legal responsibilities of all the doctors working in hospital. Consent, again I am stressing on this document. It is the single most important document which is going to save you. It empathizes with the patient. You are taking a consent from that person to have a surgery on her, so you should give the various options which are available, the advantages which will be there after doing that surgery. It educates her. She knows मला एवढे सगळे options दिलेले आहे, and then it gives her willingness also that yes, I am willing to do the same. So in spite of all these things ready, what is most needed is luck. You all will agree. Luck is needed, your support group is needed, your contacts are needed, and that is why medical josting should be discouraged. Please try to maintain transparency between you and the patient. The more transparent you are with the patient, the more the patient relies on you. Be assertive and be protective. So a correct decision can double the confidence, a wrong decision can double the experience, and so you need not worry in both situations. And if you have a situation, you are free to call me. Thank you so much for listening to me. No more wait between you and the lunch. Everything is ready. Thank you so much.